Welcome to your October staff meeting. This is our very first electronic staff meeting, and so please bear with us as we work through the kinks, but I hope you guys enjoy receiving the information this way. We have a jam-packed agenda, so let's get started. So we'll start with service. Our HCAHPS scores for new moms. As you can see in September, we took a little bit of a dip from our August scores, but you can also see at the top on the red banner that we only received 15 surveys back for new moms. This is really low. This is probably our lowest number of surveys that we've received in as far back as I can remember. So when you have one bad survey in a crop of only 15, it can really affect your scores. So really we'll just kind of pick up our boots and move forward. The lowest scoring item for this month was under care transitions for understood the purpose of taking medications. Just as a reminder, our lowest scoring item for the whole year has been discharge information, talking about help when you leave and information regarding symptoms and problems to look for. So I think we can just really focus on good solid discharge education, and that will help with the score that we are deficient on. Next up are the HCAHPS scores for GIN, antepartum, and overflow. Again, it was a pretty low survey total month. We only got 7 surveys back. It's not quite as low as the new moms, but still we looked really good actually for this population, mostly green. Communication with doctors was a low scoring item, and then also again care transitions like before, understood the purpose of taking medications. But overall, good scores in this population, and we still are looking good for the year with 4 green HCAHPS items year to date. So lastly, with regard to patient satisfaction, are our Press Ganey and hand washing scores. Again, having only 15 surveys back for new moms affected our patient satisfaction as well. We were the 89th percentile. And then for GIN, antepartum, and overflow, we were in the 99th percentile. Most concerning, I think, for both patient populations, our hand hygiene scores were only in the 52nd percentile. So a reminder that it is the expectation that you wash your hands every time you enter the room and every time you exit the room, whether or not you have touched the patient. And one of the most important things is scripting, telling the patient, I'm going to wash my hands for your safety. We were really, really good about that in the beginning when we were having the big hand washing campaign. But as a reminder, it's equally as important. We're in the 52nd percentile and we need to be in the 99th. Scanning compliance, again, we took a little dip in September as compared to August. We'd like for all of these scores to be above the 95th percentile. Here in a little bit under RL Solutions, I'll talk about some good catches that we had in the last month with medication errors that were actually caught by barcode scanning. So it is very important to scan every patient every time. Next up is teamwork. So if you are listening here, then you obviously know that we have implemented electronic staff meetings this month. I know there have been a lot of questions about how this is going to work for your evaluations and what's going to be, how are we going to get paid and those different kinds of things. So this is the answer here. So overall, we will continue to offer 1 live face-to-face meeting per month. Right now, the plan is to keep that as that first Tuesday morning staff meeting that we normally have. If we find that there are people who are wanting to come to the face-to-face and maybe feel like the nighttime staff meetings were more convenient or something like that, we can look at different times for this 1 live meeting. But this is going to be for the people who prefer the face-to-face interaction, want a paper agenda, and feel more comfortable with meeting with us to ask questions. However, if you want to do the electronic staff meetings, similar to how you accessed it today, we will upload the video version to Teams with the voiced over PowerPoint. We will load it in 2 different places. We will put it under the Files tab, and that PowerPoint will stay there so that you can watch it even after the time frame has lapsed if you need to go back and refresh. Cindy will also be uploading the minutes under Files, so you should all be able to find everything for staff meetings all in one place under the Files tab. Now in the Conversation tab, that is where we will upload the link to the staff meeting and the link to the quiz. we will put a time limit on that quiz. It will only be available for 1 week following the meetings. So this month, it will be, you will be required to take a quiz following this staff meeting just to verify your participation, and those results will be sent to us. And we will leave that link active until October 31st. So for this month, you'll have one extra day till October 31st to listen to the PowerPoint, complete the quiz, and get it submitted. Now that we will have this electronic option that is going to last for a week, staff meetings in 2019 will be 100% required. Right now we do 80% of staff meetings per year because we know you may be out of town, you may be sick, there may be scheduling conflicts, but with the ability to view the staff meetings at any time, we are going to bump that requirement to 100%. Now, that being said, all types of meetings will count for evaluation purposes. When we were fleshing out, face-to-face staff meetings versus online staff meetings, we talked at one point about, well, maybe you need to attend at least one face-to-face meeting a quarter, but we've gone ahead and opted that really if you come face-to-face or if you complete the online meeting, they all count the same for evaluation purposes. However, if you want to be paid for staff meeting, here are your options for payment. If you come to the in-person staff meeting, then you will receive admin pay as you always have. You clock out for your shift and then clock in as admin pay, and you can receive payment for the time that you're here. If you want to watch the staff meeting at work, most of the time I'm going to say that most of you won't have a full hour that you can come off the clock and watch the staff meeting, but you can. We would just ask the same thing, that if you're going to take an entire hour to watch the staff meeting, that you go ahead and clock out and clock in as admin pay for the time that you're watching. But since most of you don't have an hour in the middle of your shift to watch staff meeting, if you still want to receive payment, you can come to the hospital at an off time and clock in as admin and watch the staff meeting on one of the computers here at the hospital. If you choose to watch the staff meeting at home from your cellular device or your home desktop computer, that is perfectly acceptable, but you will not be paid for your time. Council, all of the Change Project posters are going to be due November 12th, so both of our unit-based councils are working feverishly on their posters and getting those completed. For the family care unit, you will see a post-Change Project survey coming soon. You can get information about that from Shauna. The first survey that you did prior, it will be just a repeat of that, just to assess how the antepartum education has been working for you. For the Family Birth Center, and this is actually applicable to both units, the unit-based councils are working on revising and updating our policies. All of our policies are in an old format, and we're going to be ramping those up, getting them current, getting the references current. So if you have on your mind something that you're like, we have this particular thing and we don't have a policy for it, now's the time to kind of turn that into a member of the UBC or to us in the leadership team, so that we can make sure we're not missing any policies. And then the last thing, just to clarify about huddle attendance, we tracked huddle attendance on the Family Birth Center for Lean Daily Management this last month, and there was some question about who's required to attend. And so as far as nursing goes, we would like for the entire nursing staff to participate in huddle, because it is just valuable for you to know what's going on the unit in case you have to respond to one of your teammates. But it is not required that all nurses attend huddle every day. So if you hit the ground running and have a really busy patient at the beginning of your shift, the huddle can carry on without all of the nursing staff present, but we need at least one representative, preferably the charge nurse, to facilitate and be part of that huddle. Development, I will send out this link separately because I'm not sure you'll be able to click on it from the video. But this is a quick 2-minute video that will talk to you about IPTV. So IPTV is the inpatient television program that the hospital has purchased, and it is uploaded as part of Cerner. So within Cerner, you can now assign educational videos to your patients as long as they are admitted, and they can watch those videos on their TV in their patient room. So be sure to watch this video. You actually go into Cerner through links, and then you click on the education, and there are so many different options for videos to watch. There's information in there about gestational diabetes, labor and delivery, blood sugar testing, tubules, endometriosis, pyelo, anyway, there's just lots of information that I think could be really beneficial to our patients. I'm going to be myself, I'm trying to work with the vendors to get us copies of the breastfeeding and bottle feeding videos. I just want to make sure they're compliant. So I'll get information out to you about those before we send them out. We can also make custom videos, so we'll probably be working on getting the Period of Purple Crying uploaded to IPTV, as well as some of our own specialized discharge patient education teaching. The main thing I wanted you to know for staff meeting is please be sure if you assign those videos to your patients that you document it under Patient Family Teaching Band. There is a place where you can document which videos you assigned. So I'll get that link out to you, and be sure and watch it when it comes. With regards to RQI, we know there have been a few questions now that we have finished up the third quarter and entered the fourth quarter. Just a reminder that you will all have new mannequin activities due for BLS and ACLS right now. The mannequins are in our department, so be sure that you try to get those activities completed here early in October and not wait till December. Every year you will have the new cognitive activity to complete. Everyone should have completed that in September. I will say that at the end of September, when we were wrapping up third quarter, we had several people heading into that weekend who had not completed either their mannequin activities or their cognitive activities. And the educators were having to do just a ton of texting and emailing and calling and trying to get people in to complete their third quarter activities. We really should not have to do that. You guys are all responsible to complete your activities each quarter. Earlier the better. We know there are some procrastinators out there, but if you are waiting until the very last day and then you have issues and you're not actually completing your activities until a couple days after the quarter ends, that is no longer going to be acceptable. Everyone was given a grace period for third quarter because it was our first time for the cognitive. But effective November 1st, if you fall out of compliance for even one quarter, meaning you are one day late on your activities, then you will enter the disciplinary process for that activity. So that's not really a threat. It's really more so just to keep everybody up to date. It is so important now that we're on this rolling calendar of activities, and every time you complete your quarterly activity, it adds 3 months to your expiration date. So we just need everyone to stay up on their own expirations. You can print your own cards. Links are available on the intranet and through the employee portal. And of course, if you have any questions, you can contact Lena or Tamara. If you happen to have issues with the cognitive portion on your home device, nursing education did get information that iPads are not compatible with all components of the cognitive modules. So if you were trying to do the simulations and they weren't working for you, that may have been what happened. You should have already received an email about all of the IT changes that went into place in October, one of which being the workplace violence indicator that's going to be added to the Power Chart banner. So if you have a patient that it has been violent in the past, there will be an indicator on their banner, like up next to their name on Power Chart. And then also in teletracking, there will be a tiny little V there to indicate that the patient has been violent in the past. There's also a place to indicate if a patient has been sexually inappropriate, and that will be an I. For SPAR communication, you guys learned about SBAR in the last quarterly education fair. So just a reminder that the SBAR Cardex is live. Also, we have officially switched over to vital signs being back into Bridge. So no longer doing some on paper, some in Bridge. We're doing everything in Bridge. And then the last thing is for the NSI bundle checklist. This is active in Power Chart as well. I don't think you guys will see this as often because it's really specific to CLABSI and HAPI and just different things that fortunately we do not see very often on our unit. This slide is a repeat from last month, but just your last reminder that all staff must be vaccinated by October 31st for the flu. So flu shots are out on the unit. Again, for our procrastinating friends, please do not wait till the last minute, because if you are not vaccinated by the 31st, then you will not be able to work. So this is so important to just make sure that we stay compliant and help keep our patients and babies safe. Okay, friends, we have seen quite a few dress code policy violations recently, and so I just want to put this out there, and I'll continue to put it out there every month just to make sure everyone is very, very clear on what is acceptable dress code. T-shirts are only approved for Fridays only, and each month there are only certain t-shirts that are allowed to be worn on those Fridays. We see random t-shirts all the time. I mean, t-shirts from 5 years ago in the old 3 West Tower that are still popping up. And so it is very, very important that you maintain your regular scrub dress code during the week. On Fridays, you can wear t-shirts. These are the only t-shirts that are available to be worn in October, which I know there's only about a week left. But I will say that for November, we did get approval for our bereavement t-shirts to be worn on Fridays only. So we are working with marketing to get those here and distributed. They should be in by next week, and so we will do our very, very best to get them out by the first Friday of November. I found this quote when I was thinking about recruitment and retention, and I just love it. It says, "We must become what we wish to teach." Another way to phrase that is, we've got to eliminate the do as I say, not as I do. We really have to role model the types of behaviors that we want to see reflected in those that we are mentoring. So this is applicable with our own preceptorships. If you are a preceptor and you want to have a nurse working alongside you once she comes off of orientation to exhibit certain qualities, then you need to show her those qualities in addition to teaching them. Equally important is the way that we treat our nursing students. And recently we had the New Mexico Junior College students that were in both the Family Birth Center and the Family Care Unit. And Nursing Education reached out to me regarding some of the evaluations that they got back from those students. I'm going to read a couple of the evaluation comments. It's uncomfortable, but we have to call it on the carpet for what it is. One preceptor told me that the Texas Tech students come over and are lazy and don't do anything, so that's why all of the preceptors are burned out and pissed off. I'm suffering for their actions. Another student wrote, "Please ask nurses who are willing to have a student and want to teach them not to make us feel like a burden. The nurses were not nice and the staff were not open to mentoring. Several of my peers had the same experience." So when you read comments like that, I recognize that these are a couple of comments probably in a pool of other nursing students who had great experiences. But we are working at a teaching facility. Every single one of us was a new nurse at one point, and we probably all had someone who treated us very well and someone who treated us very poorly, and it probably shaped our entire perception of that patient population, of that clinical experience, of every single thing. We can always remember those people who extended kindness to us and those who were harsh. I do not want to see any more comments like this. We have such a higher standard. We have hired people who specifically came to our unit because of their clinical experience, and I expect that from everyone. And sorry, y'all know recording is awkward, but basically this is embarrassing, and I know that we're better than this. I know that you guys are better than this, and so I just want us to provide the best teaching experience possible. We have lots of people who precept constantly, every single group of nursing students, every single group of orientees, on and on and on, and those preceptors do get burned out. And so really what will help them is if everyone can pick up a little bit of the load and be a strong preceptor for nursing students, then we can reserve the people who truly love to teach for our own internal orientees, and everyone else can work well and provide good experiences for our nursing students. On along to quality and safety. Okay, when we are looking at patient safety and quality outcomes, we will go over a few of our RL solutions from the last month. So since our last staff meeting, we had 25 RL solution reports. One of those was a medication error. It was actually related to a hepatitis B vaccination that almost got missed, and really the only teaching point that I can pass about that is that it came to our attention. I know that when you guys are filling out the hepatitis B consent forms, that a lot of that information is being pre-filled out, and then the missing pieces are being filled in when the vaccination is given. But this particular form, the vaccine didn't get sent up to the unit before the baby got transferred to the care unit. And so when the form went up, it already had a date, it already had an injection site, it already had, everything filled out except the lot number. And so really I can see that being very confusing, because then when all that was filled out, it hadn't been given and communicated well, then one nurse assumed the family must have refused it at the end. It got charted as refused. Anyway, it was kind of a whole slew of mess, but the bottom line is we want to make sure that we're communicating well with the patients and giving solid report to each other so that we know the status of those vaccinations and make sure that we don't miss any. We had 5 lab errors. 4 of them were collection issues where the date, time, and initials were missing. And then 1 was a results issue. We actually had an issue with I've said issue 700 times. And we had a problem with the urine protein and creatinine ratio. Apparently the analyzers were not working for that period of time, and so they were having to do manual calculations, and when they'd made the manual calculations, there was an error. And so a patient who had proteinuria came back looking really severe, and then it looked like there was none. And anyway, so that has since been fixed, but it did cause quite a bit of confusion for that patient over the weekend. We had 5 security events as of the weekend. We had 2 disruptions. I think that's now 3 if we're counting today. But we had 1 that was, a family member trying to get into the newborn nursery, 1 that was a dad that was having issues with the CPS involvement. So again, just a reminder to stay very safe and to de-escalate when possible and remove yourself from the situation if you are ever feeling in danger. We had 1 missing property issue. It was a lady who lost her clothing. We had, this one is worth mentioning. We did have a baby who ended up with the wrong crib card in the crib. So it sounds like it was right at admission. So it was an issue with maybe the delivery paperwork, that the wrong crib card got put in with the stack. The baby had never actually been separated from the mom. So it wasn't like they went to the nursery and the babies got put in the wrong cribs. It was the wrong crib card that got slipped in from the beginning. So just make sure we're being careful and double checking those as well. And then we had 1 issue with McRoberts where a baby made it through the double doors and into the lobby without the alarm sounding. We know that we had some tags expiring. This didn't happen to be one of them, but we are putting new tags out on the unit. Tamara's been getting those out in waves over the last week. The rest of our RL solutions were provisions of care. We had 1 issue with lactation where a baby needed a shield. Just wanted to reiterate that in that first hour of life, when the mom is doing skin to skin, it is not required for babies to have a shield for that very first feed. Now, of course, it's ideal, especially if it's a known, a mom who has used a shield with all her other kids or has flat nipples, or a late pretermer that we know is going to ultimately need a shield. It would be ideal to get that in that very first feeding, but it's not required. That very first hour skin to skin is kind of that getting to know you feed. So it's okay to do it without the shield. Dr. Hook has had a run of nurse controlled deliveries recently that are causing her some concern. I saw one of those in an RL Solutions. Just a reminder that if you are pushing with a patient, that we should not be breaking down the bed until a provider is at the bedside. So I know that this gets complicated if you're waiting on whether it be Hook or Burley or anybody private, and then tech comes in to stand by and they say go ahead and break down the bed and put the patient in stirrups. That's appropriate because you're anticipating delivery, but we also know that the second that you crank their legs back into stirrups, it becomes very difficult to delay delivery. So if you know that you have a physician on the way, it's ideal to leave the patient down in the bed and then break it down right as the provider gets there. Obviously, when there are precipitous deliveries that can't be held off, then I don't want anybody practicing unsafe and people having to crawl in beds and that type of thing. But let's try to not get the patient in stirrups until the provider is there and not break down the bed until there's an MD at the bedside. We have had in the last month 3 patients with HIV, and each time we have had a patient with HIV, all 3 of them have had an RL Solutions for something. One was the baby received the vitamin K vaccination before the bath was given. One, the AZT came up from the pharmacy. This is what I was talking about with barcode scanning, is that the AZT came up from the pharmacy, and when we scanned it into the pump, it was the wrong concentration and had to be sent back. Now, had that nurse not been super diligent and realized that it was, or had not scanned it or something and just hung it, we could have given the wrong dose, but that was a good catch there. And then we've had issues with whether or not to TC. If you take a patient to the OR that has HIV or AIDS, then they absolutely have to TC that OR afterwards. You can use your nursing judgment and discernment if you need to TC the labor room. I would say for any excessively bloody delivery with splatter and those types of things, that when in doubt, we should TC the labor room as well. But ORs absolutely have to be TC'd, and that's going to be updated in our policy. We had a patient with a latex allergy, and I sent out an email about that just to let you know that our bands that hold the monitor parts on do have latex. So if you have a patient with a true latex allergy, you need to be using the big belly bands that we keep back in the Big Pyxis and L&D, and then there's a couple in Antepartum upstairs in the drawers, because the regular bands do contain latex. We had one patient with a severe hemorrhage that ended up in the ICU. We had 1 3rd degree from a forceps delivery, and then we had a couple of anesthesia issues, one with multiple attempts from the provider and one that was an intrathecal catheter. Those have both been reported to Dr. Parikh, and he will follow up on those. The next thing you'll see on the slide is information about Harm Council. We talked about this real briefly in last month's staff meeting, but just as a reminder, we have not had any of our own staff have to go to Harm Council, but I just wanted to make everyone aware that specifically RL Solutions that result in harm and those that surround our nurse-sensitive indicators, the nursing administration is hosting a Harm Council where the director for the department and the nurses involved in that patient's care will come and report to Harm Council and discuss the events. This is really, as I said, specifically looking at the nurse-sensitive indicators, so falls with injury, CAUTI, CLABSI, HAPI, and so on. I don't know that we will see this for any of our type of patients that we've recently discussed. Those types of things are more appropriately put into a root cause analysis if we felt like there was a true issue related to harm. But if you have any questions about Harm Council, there's some information here on the slide, and I will let you know if you get invited based on one of your patients. Speaking of nurse-sensitive indicators, we'll review some of our data now. We did not have any falls with injury this month. Now, I know there are 9 nurse-sensitive indicators that are now being benchmarked across the hospital. I've added the new ones down here for your review if you haven't heard of them before. Right now, still in the family care unit, we benchmark falls with injury, and we don't benchmark anything in the birth center yet. But as they continue to add additional indicators to the database, we may start tracking more things in our units. This is a scorecard that I have not previously shared with you guys, but we receive it in Nurse Director Council, and it talks about our NIM rates. So nosocomial infection markers, that's an electronic marker. It uses a sophisticated algorithm to analyze microbiology, laboratory, and patient census data to identify those healthcare acquired infections. So we have lots of studies that show that NIM analysis finds those nosocomial infections with a high degree of sensitivity and specificity. When we look at our unit-specific data, we had 3 urine NIMs on the family care unit, 3 wound NIMs, 1 stool NIM, and 1 from an other source. And then in the Family Birth Center, we had 1 in the other category. Now this is for second quarter data. We don't have third quarter yet. But I just wanted you guys to see this, and on the next slide, I'll kind of show you what we can do with that information. Hopefully this looks familiar. This is a fishbone diagram. We talked about them in the last staff meeting, and we also have had them up on our SIOP boards this month. But basically, when you have this fishbone diagram, you put what you're trying to achieve in the middle. So over there, you'll see decreasing number of NIMs. That's our goal. And then everything branching off of that are measures that we can take to reduce the NIMs. So as I mentioned, ours were related to urine, wound, stool, and other. So when we look at wound, so here are the things that we can do to make sure that we're decreasing wound NIMs. You know, make sure that we're cleaning the area before we collect a specimen, that we give pre-op antibiotics effectively. When it comes to urine NIMs, make sure that our Foleys are anchored per policy, that we're using aseptic technique during insertion. For all, which I think is the only thing we can use for quote, quote, other, is that make sure that we're using appropriate techniques when we're collecting specimens, that we're careful when we're getting blood cultures, that we're labeling things correctly. So I just wanted to make you guys aware of this, and we will continue to track our NIMs. It shows up on our evaluations, and so I wanted to be able to discuss it with you. We have a very low rate overall comparatively to other areas of the hospital, but just wanted to make it available so that we know where we can improve. Reported this data at last month's staff meeting, and nothing has changed. It's still only ND and QI data for quarter 2 is available. So we were above the mean for falls with injury in the FCU. So we do have an action plan in place for reducing maternal exhaustion, since both of our falls with injury in that quarter were newborn. And so we'll continue to be working on that. For lean daily management, we right now do not have word that we will have any mandatory topics, so we'll go with 2 topics for each unit, and if that changes before November 1st, I'll be sure to let you know. So for the Family Birth Center, the first topic will have to do with CAUTI prevention. So on the next slide, we'll look at the fishbone diagram for CAUTI, but just know last month we looked at sterile technique for Foley insertion, and this month we're going to be looking at pericare. So making sure that according to policy we perform pericare a minimum of every 12 hours once a shift for all patients with a Foley in place. And so we will just ask that the charge nurses or their designee observe someone performing appropriate Foley care with the purple wipes. The second thing we're going to be looking at is cost reduction. So we've been reporting for a long time about the lost pharmacy charges related to Pitocin, and this month's report is no exception. We actually had 78, I did not misspeak, 78 bags of Pitocin that were pulled from the Pyxis and not credited in the Pyxis. So that is people pulling out 2 bags and only charging for 1. It's people just pulling bags out, not charging for any. So the way that we'll be monitoring this is we're going to be asking the charge nurses to select up to 5 patients per shift. So if there's not 5 patients, you can do less, but if there is, you need to do up to 5 patients per shift that are on Pitocin, and it will be unfortunately kind of an extensive audit while we're working on it, but we'll ask that charge nurse to go to the bedside and see if there is a second bag of Pitocin in there for that patient, and if there is, we will have the charge nurse log into the Pyxis and make sure that both bags were pulled. Now, we are not asking the charge nurses to fix it. We're asking the primary nurses to do that. The charge nurses will just audit. If they're finding bags that have not been charged, will be read for that day, and we're asking the primary nurses to then fix that pull. Mention Fishbone. So last month we were up on insertion looking at sterile procedure, and now we are down on the maintenance bone and looking at pericare a minimum of every 12 hours. For the family care unit, we are also going to be looking at CAUTI prevention. Same as the Family Birth Center, we'll ask that you verify pericare every shift for all patients with a Foley in place. I have here bolded and underlined document on the ICPP. As a reminder, we talked about this at last month's staff meeting as well, but Lena and Tamara have binders out on the unit with your ICPP forms in them. I think it's a coral binder on the birth center and a blue binder on the family care unit, and you have certain skills that have to be verified by a peer. One of them is Foley care, or insertion. So if you are observing someone complete Foley care, please sign off on their ICPP. The second topic for the family care unit is going to revolve around baby-friendly education. I will talk in the next couple of slides about our baby-friendly AQI audits, but we were really struggling with formula feeding education for our formula feeding moms. The specific question on the audit says, did the mother confirm that she was given both verbal and written instruction on preparing and feeding formula? And we were essentially at 0%. So it is really, really important that we are not neglecting our formula feeding moms when we are providing education. So we're going to ask the charge nurses to audit up to 5 patients per shift that are indicated to be bottle feeding, and make sure, visit with the mother. It's not a chart audit. It's a visit with the mother to make sure she has been given instruction on how to prepare formula. I know that we were giving the orange folders for formula feeding parents, and we are no longer doing that. It's all been defaulted to the DPART process, but that education needs to be given sooner than later. Please do not wait till discharge to discuss that with the patient. So same as with the Family Birth Center, this is the Fishbone for CAUTI prevention, and it will be up on the Lean Daily Management graph. So as y'all know, for Baby Friendly, every year we have to submit data to show that we are continuing our education and efforts at the hospital at Baby Friendly standards. So these are the results of those audits for our 2018 AQI. Unfortunately, our step 3, which is prenatal education, almost all of our measures were found to be deficient, and so we will be repeating this step with an action plan in place over the next several months, and have to get these scores up to above 80%. Now, partly responsible for step 3 being low is the fact that we no longer have clinics affiliated through PNS or UMCP. So when we got designated baby friendly, this was Dr. Fernandez, Dr. Varma, Dr. Scott. But now that those are no longer our affiliated clinics, we're kind of having to start over with Health Point and Grand Expectations and the Texas Tech Pavilion. So I'm not surprised by these scores, but we do have work to do, and most of this work is to be done in the clinics. The one thing that I feel like everyone here can take ownership of and help us with is when you are caring for antepartum patients or even triage patients, to provide education when possible about the benefits of breastfeeding, things to expect when they're admitted to the hospital, the benefits of skin to skin and rooming in, of exclusive breastfeeding. Any type of education that you can provide would be beneficial for this particular step. Just the remainder of that audit, along with our action plan, which essentially says that we are going to be working closely with the new clinics, not that they're new, but they're new to being ours, and that we will be educating that clinic staff, we'll be providing quarterly in-services to them, and that we will be implementing the same flip charts and educational initiatives that we had in place over at Fernandez and Scott's clinics. We'll be putting those into the tech clinics as well. So steps 5, 8, 9, and 10 have to do with everything from feeding on cue to hand expression and positioning, pacifier usage, formula feeding babies in the NICU, and then also community resources. You can see our results here. We were 100% on feeding on cue and positioning. We have a little work to do on making sure that all of our moms are being shown how to express their milk by hand. And then we've done well with pacifier education as well. Then these are the scores continuing down for this audit that, you know, our exclusivity rate and were moms taught about where they can get information and support when they go home. So a reminder just to be talking to everyone and scripting about our 24-hour lactation pager if they need it. So questions 9, 10, 11, these relate to formula feeding. I have highlighted this one in red about did the mother confirm that she was given both verbal and written instruction on preparing infant formula. There were not a ton of moms audited that had formula feeding, but I happened to find the only 7 who had really favorable responses. There were quite a few that indicated that they had not been given instruction on preparing and feeding their baby formula. So we've got to really ramp this up. This is part of why it's a lean daily management topic as well. A reminder that you're wanting to teach the moms to hold the baby close, to make eye contact, that you're still feeding on cue. And then the other one that was shown to be delinquent in several of the charts that I looked at was whether or not moms with babies in the NICU were taught to express their milk using both methods, so hand expression and an electronic pump. Most of them indicated that they had been taught how to use the pump, but not to hand express or vice versa. So it is an expectation that they need to do both. Moving on to stewardship. So I already kind of spilled the beans on our lost pharmacy charges, but as I mentioned, we did not have much improvement on our Pitocin situation. We had 78 bags of Pitocin that were not accounted for, which accumulated to over $600. In the family care unit, we did have less expensive medications, but we had 15 tubes of lanolin that were just pulled without being accounted for. More concerning, again, not as expensive, but still just concerning, we did have an MMR vaccine and a Tdap vaccine that were both unaccounted for, and the 2 of those combined was over $100. So just to be careful and mindful of that. The nursery lost a couple vials, it looks like 4 vials of lidocaine. So just being sure that when we're pulling things from the Pyxis that we're crediting them appropriately. Okay, well, this one breaks my heart. So we found out this last week that hospital administration, not nursing administration, but hospital administration is prohibiting departments from purchasing individual Christmas gifts for their employees. So essentially, every department is given a budget for reward and recognition. And for years, the way that we have chosen to utilize our reward and recognition budget is that we do small things throughout the year. You know, if you guys need a pizza on a busy shift, or if we, you know, at staff meetings, we give movie tickets and candles and lotion and stuff to our employees of the month and WOW scorecard recipients. But for the most part, we just do little things. You know, sometimes we have those quarterly celebrations, yada, yada. But we save the bulk of that budget for a nice Christmas gift. We've done jackets and Yeti cups and different things like that that are expensive, but we are able to do that because we've saved that money throughout the year. What administration prefers that we do is utilize that money more evenly throughout the year and not create kind of a shift in the balance of the way one department does it versus the other. So if one department's getting, chapstick and a brownie for Christmas and you guys are getting a Yeti cup, then it seems unfair. So we are going to roll with it, and what that means for this year is that we have saved all year for Christmas gifts, and now we have a budget that needs to be spent. So we are going to be putting together a smashing Christmas party, and we will try to have maybe some door prizes and catered food and just make this a really great time for you guys to be able to come and your families. We will do it off-site so as to just make it more festive, be able to utilize the money that we have and create a really great party for you guys. We'll also use some of that money, since we have Thanksgiving and Christmas both approaching. People who, I know that typically the units do a meal, like a potluck, and so the department will purchase the turkeys and hams and stuff so that you guys, I know that can be an expense, so we'll use some of the money for that to make sure that we have something nice here for the people who are working on the holidays. If you have questions or comments about this, again, we're disappointed. We like the Christmas parties and the Christmas gifts that we're able to do, but we will just find more ways to utilize that money throughout the year. And we've already got some great ideas in the works about how we'll do maybe additional retreats or just different types of gifts, ways to reward and recognize you guys during Nurses Week and on the minor holidays and those kind of things. So we will make lemonade out of lemons. Let me know if you have questions. A few things that came out of OB Collaborative. So first up, this is kind of a big change too. Whew, this is a jam-packed staff meeting. Mercy. One of the DNV citations when they came to the hospital pertained to the OR and OR attire. Now, it was not identified in the Family Birth Center. It was identified in the main OR, but because we are both ORs and one facility, the changes that are going to go into effect will affect all areas. So basically, the DNV surveyors felt that our operating room attire was not meeting policy. They identified nurses that were walking in and out of cases with masks hung around their necks and just pulling them up when they went into the room and letting them dangle around their neck when they came out of the room, and so on and so forth. And ultimately, they were saying the masks have to be put on when you go into the OR, discarded when you come out, and you put on a fresh mask each time you go in and out. So I know that sometimes when we're preparing for a delivery, you have a patient going back for a C-section. I see our nurses all the time walking around with masks around their necks. Just know you can't do that. We are going to be going by the American College of Surgeons, so ACS. The ACS standard says masks should not be allowed to hang or dangle around the neck at any time. The other thing revolves around scrubs. So essentially it says OR scrubs should not be worn at any time outside of the hospital perimeter. So for our OB techs, it is already the expectation, since they're wearing hospital scrubs, that they come into the hospital, change, and go home in their street clothes. That is already the standard for them. This will be a change that goes into effect for our labor nurses, especially those working in the OR. So we are still fleshing out some of this policy, when it's going to go into effect, how it's going to go into effect, but I just wanted to make sure that you guys are aware that it is coming, that the L&D nurses will be switching to hospital scrubs. The alternative, there is some conversation out there about the ability to be able to wear home laundered scrubs. But even with home laundered scrubs, you are still required to change once you get here. The issue is, wearing the scrubs out in the community, in your car, or, wherever, and then coming into the OR. So the hospital policy isn't changing just yet. It will be. We just have to have our action plan in place for DNV within the next 60 days. So I am anticipating that we'll be seeing some of these changes at the beginning of the year. Questions or comments, be sure to give us a shout, but there is quite a bit to be working on there. The next thing we talked about in the OB Collaborative is Little Baby Care. Now, this is the initiative coming out of the NICU, where the NICU is creating policies for infants less than 29 weeks or less than 1,000 grams. And so the main things that they're looking at that will affect our area is just, again, making sure that the delivery room is 78 degrees. There are these cute little ponchos that they're going to be using. If you're in a face-to-face staff meeting, you'll be able to see those. If not, I'll try to get examples for y'all to be able to see. But ultimately, they're really going to be working with the OB team to make sure that we have antenatal steroids given in a timely manner, that the babies are being ponchoed at delivery. They are in a sterile package, so we'll be dumping those ponchos onto the table in the OR so that the docs and the OB techs can get the babies in those ponchos while they're awaiting delayed cord clamping. We know for these little bitty babies, delayed cord clamping is super important as well. So anyway, there will be more information to come, but I just wanted to make you guys aware of that. IT was present and talked about the issues with our phones. We know that the Cisco phones are a dying breed, but they actually got quite a bit better with this latest Wi-Fi patch that IT was able to complete. The CareAware devices that we're all going to be switching to, the ones that the charge nurses are carrying now, those are actually having more issues than the old Cisco phones now. So the latest I heard is that IT is going to be getting us some more new Cisco phones, like the newer models, like the ones that the family care unit has, since they seem to be working a little bit better with the Wi-Fi while they continue to tweak out the kinks with CareAware and the Jabber app. And then the last thing is just under security, we do have a new door code coming that changes effective November 1st. You can check your email to see that, but essentially the new code is going to be 7465, which is pink spelled out. Also, since we're talking about pink, we discovered during DNV, and I mentioned this in the OB Collaborative as well, that when we switched to plain language codes a couple of years ago, I was under the impression that code pink was not one of the codes that changed, that we would still say code pink, but it has changed, and that will now be called out as a missing person, and then they would describe the missing person as a newborn. So just so that you're aware, if you hear missing person, family birth center, newborn, you're not like, what the heck is that? That is code pink. It is a plain language code. We also talked quite a bit, since I'm running a little long here, I'll send out more information about Code Silver, but essentially there were some concerns with the HUCs about the doors to the units that are keypadded on each side and the safety for that person sitting out front. And ultimately, I just wanted to clarify that when those doors were installed, it was because we had about 3 visitors within a month that had jumped over that desk and entered the unit because they didn't want to wait on someone who wasn't sitting at the front desk. And so we identified it as a gap in security, that there's really nothing preventing people from entering the unit if there's not a keypadded door there. While it does make that unsafe if there's a shooting right at our desk, if there's a shooting pretty much anywhere else in the hospital, then our staff can retreat behind those keypadded doors and at least start that multiple layers of resistance process. So we will be keeping those double keypadded doors. It is for everyone's protection. And ultimately, again, just a reminder of de-escalation, removing yourself from any situation that feels unsafe, and if at any time someone in the lobby is feeling unsafe, then they should enter in behind the keypadded doors. Bend to growth. This is a repeat slide from last month, but the hiring status is the same. We are fully staffed in both units. We still have 2 OB techs and nurses on orientation, but they should be wrapping up shortly. I will let you know if we open up any new positions. Drum roll. Our employees of the month for the Family Birth Center was Candace Loper on days and Danielle Day on nights. And for the Family Care Unit, it was Jada Chapa on days and Julie Merrick on nights. So, woohoo! I need to get some sound effects. That's going to make this thing awesome. Y'all just wait. It's coming. I'm going to get sound effects and we're going to be telling jokes. You guys are going to love these meetings. Last slide, our upcoming events. Just a reminder, fourth quarter O3s are going on right now. Everybody has until December 31st to have an O3 with me. Normally you do your O3s with the person you directly report to, but in the fourth quarter I do everybody. So there is a sign up on my door currently. I'm adding new dates as those pass by. So just don't wait till the very last minute, because y'all know that is going to be like New Year's and there's going to be stuff going on. So don't procrastinate. Fourth quarter education fair is coming in December. We'll give you more updates as that comes along. October 30th is NRP in the nursery. You should already know if that is you and if you were required to be there. So we look forward to seeing you there. We did it. Good job, guys. Happy staff meeting.